Sounds like we have some
Okay, nice.
background information coming from you,
So
Dee Dee.
backup for remote.
So like
All right,
right now, well, actually,
all right, so we're going to start with Sam, if she is on the line from the Inlander.
Yeah, I'm here. Can you guys hear me okay?
Yes, thank you.
Okay, so I had a couple of questions. First, I'm wondering if any additional staffing has been brought in from sort of travel services and federal services that we've seen. I know over at Kootenai Health, they've had to bring in, I think, 2 or 3 different options at this point to have enough staff to work their ICU.
So in regards to extra help, we've submitted requests to the state and we've not yet heard back on the answer from that. Travelers, we've done everything we can to get more travelers, and travelers are incredibly high demand. And so you're competing with a national market. And you know, we're paying very, very high rates. We're trying to recruit as much as we can, but we've got really not as much as we had hoped to get. The kind of heart-wrenching move that we had to institute this week was really to further delay surgeries. And I think people think when we talk about these surgeries that we're delaying, we're talking about non-essential minor surgeries. And we're talking about, you know, removal of cancers from people and orthopedic injuries that are causing constant pain for people that we can fix. We've paused those to try and deploy additional staff in our hospital to help care for ill patients. And as of today, I think we redeployed roughly 50 people that would normally be in the operating room, working as teams to care for surgical patients so that we can provide additional care on the medical floor. And we're working on expanding our ICU capacity. So we're really doing everything that we can to extend our staff with our current resources.
Sure. And I know you sort of mentioned this in your introduction, but I think people are kind of stressing out and worrying about, they see Idaho at crisis standards of care and they're hearing those surgeries have had to be delayed for you all so you can sort of redirect your staff. Can you talk about sort of what will make that breaking point, what it would take for us to get to crisis standards here in Spokane?
Yeah, well, just one point of clarification. You know, I think there's this impression that our situation is entirely related to Idaho's situation. And we're separated by an imaginary border. Although our vaccination rates are higher than what they have in North Idaho, we have certain pockets near us that are lower or not much better. So this really is a crisis that's created not because of what a state's doing, although there's certainly measures they could take to improve their infection rates, but this really is an issue. It's a crisis that's created by low rates of uptake of vaccination, not just in their community, in our community. So I think that's the biggest point. Crisis standards of care, when you talk about crisis standards of care is every physician's worst nightmare. And I got to live through that when I practiced in a Chicago emergency department when an Amtrak derailed. Now that situation I was in lasted roughly 2 hours and then we were out of it. We're dealing with an emergency that just keeps getting worse and worse and worse, and we're not sure where it's going to end. And when you talk about crisis standards of care, that's when you've really utilized every single scarce life-saving resources that you have. You've deployed them all. So the example that I think that's probably most common is if you have one ventilator and you have 3 patients who use the ventilator, how do you decide who gets that life-saving resource? Or dialysis, who do you decide who gets dialysis and who doesn't? Who gets a bed in an ICU and who doesn't? That's crisis standards of care. We're not there. We're not there yet. We could certainly get there. We're in a high contingency standard of care where we're providing standard care in a non-traditional setting. But in reality, it's not standard of care. We're providing for patients who would normally be in an ICU outside of an ICU. And so we are stretched to the point where I can't tell you when we'll be in crisis because it changes. We figure out where we can shuffle patients and shuffle resources. But if one hospital enters crisis of standards of care, the whole state's going to do everything that they can to level load patients across the state. We have the WMCC that helps with that. We have relationships here locally where if I have a patient that can't get the care they need, we're going to do everything that we can to get them to a hospital that can, whether it's multi-care or it's Harborview. We're in this together as a state.
Do you have any follow-up to that, Sam?
No, thank you so much.
Thank you. Ariel with the spokesman review.
Great, thank you. I have a couple follow-ups on what you were just talking about, Dr. Getz. How many staff and what positions are we talking about has Providence asked the Department of Health for? And then could you elaborate a little bit on expanding your ICU capacity? You know, are we talking about using a different wing of the hospital that's not typically the ICU?
So I don't have the exact details on the type of staff that we requested, other than that the majority of them were nursing staff. I think when you look at the current situation in healthcare, no matter the state, we're short in everything. Healthcare is the ultimate team sport, and whether you're a patient transporter or you're a phlebotomist or you work in lab or you're an RN, you're a physician, everybody's role is equally important, and we're short across the board, and there's a number of reasons for that. As far as expanding our ICU capacity, I have, earlier in the week, I had 17 patients that were on medical floors that would have traditionally been taken care of in the ICU, and we're able to deliver equivalent care to them in that setting. What we're exploring right now is creating additional ICU space in our PACU, which is normally our post-operative recovery area, where we can deliver ICU level care for maybe the less labor-intensive ICU type patients, as compared to those that are on ventilators and need proning. Today, I have 18 patients on ventilators in our ICU. Not a single one of them is vaccinated. And I want to just highlight that point. The vaccines, not only are they very, very safe, but they're incredibly effective at keeping you from getting very, very ill from this and dying from it.
Great. My other question is, what does transfer capacity look like? I know that, it's been tight. We have critical access hospitals sort of treating COVID patients and holding them. I'm curious, I know it's an hour by hour thing, but has that in recent weeks tightened up or become, easier for you to accept patients from the surrounding critical access hospitals?
Transfer capacity across the states become more challenging. We received a call, for example, from Nevada the other day requesting that we could accept a transfer. So across the state here locally, it's becoming more and more difficult. Historically, we're roughly able to accept 90% of the requests from our areas for transfer of patients into our facility. And we're a quaternary care center. We're kind of the largest, most sophisticated hospital in this region. And we provide high-level cardiac care, stroke care. We're the only trauma center. And now we're struggling to accept half of those patients. And the big concern is in these more rural, less resourced hospitals with small emergency departments, if they start having difficulty transferring patients out with things like strokes and heart attacks, it's going to lead to unnecessary death. So that's why we have the WMCC in place across the state to help level load patients, but it takes time to get a transport team to take a critically ill patient across the state. Sometimes those patients aren't stable for transport. That can lead to death. So there's a lot of steps involved to getting a sick patient out of your facility into a more capable facility, and it's only getting more difficult by the day.
Great, thank you. My last question is, I know Sacred Heart has the Children's Hospital and the only PICU in the region. I'm curious if you're coordinating with other hospitals, not only in Eastern Washington, but in North Idaho. Should they have pediatric patients with COVID that need more intensive care? Is Sacred Heart sort of preparing to be the care center for those types of patients?
Was the only pediatric hospital in the region. We've kind of been prepared. We've delivered that service to the community since the beginning of the Children's Hospital, and we're prepared to handle the sickest children as they come. Thankfully, although this is a horrible disease in children, it's still largely affecting adults, and we have capacity to care for more sick children. But it's also important to realize that we have more children that are sick with COVID than we've ever seen throughout the pandemic.
Thanks.
Thanks for your questions, Ariel. We'll go to Dee Dee with Cairo 7.
Hi there. Thank you so much for doing this, Dr. Getz. I am wondering, you mentioned, having to at times send patients to Seattle as well, to Harborview Medical Center, as you're struggling to accept as many patients as possible from, for instance, Idaho and other states as well. I mean, how often are you finding that you do need to send patients over to Seattle as well, and what kind of circumstances generates that need? And then part two is, how often are you needing to deny those requests from other states? I know you mentioned the numbers a little bit earlier, but if you could get into both of those things, I'd appreciate that.
Sure. We've had a long-standing history of partnership and collaboration with Harborview, especially as trauma centers. So although we're the only trauma center in the region, there's certain things. For example, burns. We don't have a burn center, a burn unit. So we would transfer burns over to Harborview for care. Multi-digit amputations. We can generally attach most things, but there's certain things that they require the specialty care that Harborview delivers. So we transfer those things over. Patients that are getting transferred now out of our community over to Harborview for things like COVID care are really just patients that we can't accept because we are saturated. We don't have the resources, and it's really people, place, and stuff. So you have to have the people to care for the patient. You have to have a place for them in your hospital, and then you have to have the equipment required to care for them. And if we don't have those and we can't care for a patient, it's in the patient's best interest to send them to a facility that does. And we're seeing all over across the state we're doing this. We're not only sending patients over there, we're certainly taking patients from the west side of the state to our side of the state. And that's where the WMCC has done a good job of coordinating. And the governor's done an admirable job in declaring that if we reach a point where we're in crisis standards of care, this is not an individual hospital problem, it's a statewide problem. And we're all dedicated to providing that care to those patients in any area that has capacity. So we're really trying to make sure that we're aware if we're approaching that point, we're appropriately sending patients to areas that have more capacity to care. And I might have forgot the second part of the question. If there's
yeah, that's quite all right. It was actually a separate question. And then, so, I mean, you mentioned that historically you're able to accept 90% of transfer patients, and now that's down to 50. And so, I mean, when hospitals are calling with COVID patients and they're in the situation, maybe in a crisis standard of care, and you just have to say no, you just have to make that tough decision and say no. Is that how it works?
That's how it works, unfortunately. And we do everything we can. We've had physicians that we don't have the capacity or the staff to care for a patient. And so we have physicians that are getting on the phone and helping some of these smaller rural hospitals deal with sicker patients than they're traditionally caring for. Really, we're doing things, we're trying to be innovative and do everything that we can to expand capacity. But this is uncharted territory. We've never had to do this.
Thank you. And just finally, can you help me get a good understanding of, I know you're saying this is the worst it's ever been, but how close are you to having to need to do that to make that decision? Okay, who gets the ventilator?
In the specific case of ventilators, we're still well supplied with ventilators. One thing that we've learned over the course of COVID management since the beginning of the pandemic is that if we can avoid ventilation until absolutely necessary, patients do better. So I think it would be unlikely we reach that point as our declaration of crisis, but things like dialysis are becoming exceedingly tight. Just traditional ICU bed space is becoming more difficult. I think those would be, some of the resources that we could see tipping us into crisis standards. And how close we are just depends on the given resource that we're discussing. It was a ventilator issue. If you're completely out of ventilators, you can sometimes put two people on one ventilator split, but you're doing things that you haven't traditionally done. And it could take, one or two bad nights to tip you into that. And I'm incredibly concerned that we have a big fair going on in Spokane. That makes zero sense in the middle of a pandemic. And we're hearing reports that we're lucky if a quarter of those patients are wearing masks. And so what it tells me is the community doesn't understand the level of crisis that we're dealing with. They don't understand the incredibly difficult decisions that we're making and delaying care in people that have cancers that we should be reviewing now because we need to make space for them in our hospital in case they get sick. And ultimately, it comes down to a choice of vaccination. And I hear the argument over and over again that it's a personal decision, but I'll tell you, it's not a personal decision. Because if you require hospitalization and care, it's taking care away from that patient with cancer that's waiting to get that removed. It's taking care away from that patient that he needs their hip or their knee replaced. This it impacts us all. It's a population health issue.
Yeah, I hear you. Thank you so much.
Thanks.
Thank you. We'll go to Caitlin with KXOY now.
Hi, can you guys hear me?
Yes.
Perfect. How many pediatric patients are being treated right now, and how many are not eligible for a vaccine?
Caitlin, I apologize. I missed the first half of the question. If you could repeat it.
Yes, sorry. How many pediatric patients are being treated right now, and how many are eligible or not eligible for a vaccine?
I don't have my exact numbers at this point. It seems for the last couple of weeks, we've been hovering around 10 patients is our census. And I know on some of those days, roughly half of those patients would be too young. They would have not have been eligible for vaccines.
Thank you.
Thank you.
Tim with KHQ. Tim, you might still be on mute. Well, he dropped his question in the chat, so I will just read it. How accurate was the New York Times profile on the current situation with patients coming in from Idaho?
So I think the New York Times story was fair. Had I written it, there'd be a couple of things I would include. One, I want to commend the medical team at Kootenai. They're working incredibly hard, doing everything they can to care for their community. And so they're as tired as anybody else is in the rest of the country. They're taking care of an excessive number of COVID patients, and they really are. They're functioning as heroes in that community, and we're in this together. And I think that needs to be clear. Secondly, we're not much better in the vaccine realm. So, although North Idaho is a little bit worse off in vaccination, we've not had great uptick in our community as well. We're lagging behind the west side of the state. And so it's our obligation as members of a community to do our part and help those that are more vulnerable. That's why we're encouraging vaccination. And it's frustrating. You look at countries like Denmark, they're getting rid of their COVID restrictions because over 80% are vaccinated and COVID's not a public health threat for them. I have 18 people in the ICU right now that statistically, if they were vaccinated, would not be on ventilators. When you're unvaccinated and you get put on a ventilator for COVID, the odds of you getting off of that and living, it's roughly 60% chance of dying. It's like a flip of a coin, basically. Are you going to live or going to die? I mean, this is a horrible disease for people to get stricken with it. And I can't figure out why we're stuck in a spot right now where people don't understand how bad this is. And I get it. If you're not a healthcare professional, if you don't see this day in, day out, you walk into the fairgrounds, it looks like life is normal. And so you think the pandemic's not real because you're not dealing with that patient who's on death's door that can't see his family to say goodbye before they're intubated.
Thank you, Dr. Getz. We've made it through all of the comments in the chat, so I just want to open it up for any follow-ups. As a reminder for those who have joined late, if you want to put your name and news agency in the chat, we can get to you.
Dr. Getz, it's Dee Dee here. I have a quick follow-up. Are you able to share any further clarity? I know you were saying that you guys also sometimes accept patients from the western side of the state, but how many patients have you had to send to Harborview in whatever way you can quantify, whether it's in recent months or, over the last week, something like that? Is there a way to quantify how many patients that you're needing to send to Harborview for COVID treatment specifically, and put it in comparison for maybe when it was better?
Yeah, it's tough for me to say specifically COVID patients. Historically, when I was working in the emergency department at Sacred Heart, which I did for 13 years, it was pretty common, maybe, a handful of times a month where we'd have a trauma situation, which required a higher level of care at the level 1 trauma center. We would send that over. To my recollection, it's very rare that we as Sacred Heart are sending COVID patients over to the west side. But those rural hospitals, and there's tiny hospitals scattered all over eastern Washington and central Washington that can't deliver the high level of care that we can here in their own facilities, they're reaching out to everybody that has a bed. And so if Harborview can take a critically ill patient out of a tiny little hospital quicker than we can, they're going to go there and vice versa. And that's how it works across the pass when patients come to us. It really is time critical. The quicker we can get a patient to a facility that can deliver the highly specialized care it takes to recover from really bad COVID disease, the better the patient will do. And so that's why in healthcare, we review these lists every day and multiple times a day of patients that are requesting transfer in. And we're trying to do everything we can to give a yes to these facilities, because I understand, having worked in tiny hospitals in rural areas before, how isolated you feel and how alone it is when you're caring for a patient that really does deserve to be at a hospital that has more resources.
Gotcha. Thank you.
Thanks.
Any other follow-ups we can get to? We have about 7 minutes. Tamara, I see you typing with Krem. Do you want to hop in there?
Thanks. We've heard some non-medical Providence employees have been giving some volunteer shifts in the hospital and in the ER. Is that correct? And
we're using volunteers in different spots. Wherever we feel like we can deploy somebody that has some sort of expertise or a skill that we can offer that we're short, we're glad to use. We have one of our longtime members of our previous executive team, Ann Hurst, who's coming back to help provide palliative care services. We're to the point now where we're so stretched with specialty physicians and nurses, as well as social workers, chaplaincy that provide end-of-life care, that we're struggling to provide, care in the face of death and dying, which is a critically important piece of the whole paradigm of care. And so we're using everybody everywhere that we can.
Tamara, do you have a follow-up to that? Great.
No, that was super helpful. Thank you.
Thank you. Ariel with Spokesman, we'll go to you next.
Thanks. I'm just wondering if you can elaborate a little bit more, Dr. Getz, on ICU capacity. It sounds like that's sort of one of your big pinch points besides staffing. Could you talk a little bit about, I'm guessing ICU beds in the entire region are tight, and just a little bit about why ICU capacity needs to expand, whether that be COVID patients are sicker and then just normal acuity of patients are sicker. You're sort of, it's my understanding you're dealing with a double sort of double impact, if you will, on the ICU needs.
Yeah, sure. So ICU capacity, I can't remember the last time we dipped under 90% capacity. And we have at Sacred Heart, for example, the biggest hospital in this region, we have 50 ICU beds. And not always are we able to staff 50 ICU beds because you have to have the ICU nurse available. But for the most part, we're staffing those 50 ICU beds. And then we always have transfers for patients in our own hospital who start to decompensate. They're looking sick enough that they probably should have some ICU care, and we're not able to transfer those in. I had at one point 17 patients that probably should have been in ICUs, but we couldn't get them over there. And so we cobbled together the care the best that we could there, and they got the right care, but not in an ICU setting. The problem with COVID, one, we're not just dealing with COVID patients. We deal with the heart attacks and the strokes and the bad traumas and all the other horrible illnesses that at times require ICU care. So we're dealing with normal disease. And now you stack today 18 patients who are in the ICU with COVID. And COVID is so challenging in the ICU setting because once a patient's on a ventilator, it's not uncommon for them to take 2 to 3 weeks on that ventilator. And ventilators get cared for in the ICU setting. So if a patient's intubated and they're on a ventilator and they're in our ICU, we're breathing for them with a machine. They're in our ICU for 2 to 3 weeks. It makes it very difficult because these patients keep stacking up. And that's what's been so challenging with ICU capacity during this peak that we're seeing is we have more sick COVID patients coming in than we can deal with at one facility throughout the state. So we're obviously distributing them. I think in our region right now, we're roughly 330 patients in hospitals with COVID, and that includes Kootenai, our 2 hospitals in Stevens County, as well as the multi-care facilities. But we have 330 patients, and for perspective, 330 patients would basically fill up Holy Family Hospital with COVID only. So we've got a hospital worth of patients just in our region with COVID, and if you add up the ICU numbers between everybody in that region, it would be 2 to 3 ICUs worth of patients, many of them on ventilators.
Thanks, that's super helpful.
Thanks.
We just have a few minutes left, so does anyone else have any other questions you'd like addressed in our time together today? All right, Dr. Getz, do you want to share a closing remark and then we'll wrap this up?
Yeah, thanks. I know people are tired of hearing it, but I can't stress the importance of vaccination right now. I feel like we've been bombarded with disinformation as the general population. I know it's hard for people to sort through that. I kind of call it Jenny McCarthyism, right? It's anti-vax, but to the next level. And whether it's a celebrity or somebody who, feels they're a Facebook medical expert and posting disinformation, I want them to realize that it's causing people to die. And these are very real people. The vaccine, nothing's 100% safe, but has proven to be in large numbers incredibly safe, highly effective, and is certainly our way out of that pandemic. Next, it's incredibly important that we mask. And I know people are tired of wearing masks. I'm sick of wearing masks. But masks are proven, and you can pull the huge data, right? You can't argue this. Masks are proven to reduce the spread of COVID. And we see this in states that don't have mask mandates, including our neighbors across the border in Idaho. We need to embrace those proven tactics that we know reduce the spread of COVID, or we're all going to progress to that point in a period of weeks where we saturate the resources that we have to care for our community. And that's all I have.
Well, thank you, Dr. Getz, for sharing your expertise. And again, thank you to all the journalists on the line for sharing your time with us. We appreciate it. You have my email, but I've also dropped it in the chat. If you have any follow-up questions, just please reach out directly to me and we will do our best to get those answered as quickly as we can. Thank you all again for your time and stay safe out there.
Thanks so much. Take care.